please.
I also just wanted to mention independent medical reviews. One of the other really critical roles that the Department of Managed Healthcare takes is that they track the results of the outcomes of the independent medical reviews, and they look for patterns, and then based on those patterns they can pursue enforcement. And in a lot of history I've had the same issues over and over decided one way by a medical review, and it's been really critical to have that monitoring organization. And it's just so much easier for consumers to access. I've had many families try to call the Ombudsman for the Medi-Cal side that's accessible by the COS plan, and they never get any response, whereas the help center responds immediately. The family I was talking about, Megan, was told she was not eligible to appeal and that there was no denial. So I don't even know whether her denial would have been counted in the statistics, which may be why the statistics are so low, because these families do not have a lot of understanding and ability to navigate a complex system.
Dr. Wood?
I appreciate that. It sounds like there are multiple issues here. Then, if we can't get phone calls, answered in a timely manner, so I'm concerned about that as well. So, and I'm passing on a message. I have a couple other members who approached me at lunch who represent an area that's covered by another coast plan, and they're not really sure of the need of this as well. So my question about the IMR, I'd like to direct to the opponents just to get their perspective as well.
Thank you, Mr. Wood. So just to be clear on the IMR, the subject of independence was brought forward. We have actually said we would contract with the exact same entity that the Department of Managed Healthcare contracts with now, if that's what would make people happy with regards to an IMR process, to make sure it was completely independent. The other thing is, I don't want people to have the impression that the health plan itself might deny a certain treatment, and then the next step is they have to go through an IMR. The county organized health systems already have a contract with an outside entity of medical professionals, and it's for a second opinion. So if you get the initial denial, you can appeal it for the second opinion among doctors. Now, granted, we pay for the service, but they are not employees of the health system, and that is the initial review to determine whether the determination was accurate or not. If they don't like the answer they get there, then they can proceed to the administrative law judge. But again, we've said if it's because you don't like an administrative law judge as opposed to a doctor making that final decision, we would be happy to contract if that's really what the crux of the issue is. The one other issue that was already brought up with regards to, and it was noted in your analysis about the audit of the Department of Healthcare Services Ombudsman helpline, I think that is a completely valid issue that this committee and the Senate Health Committee should look at to determine why there is a backlog. That's through the Department of Healthcare Services. Perhaps some of the money that we would otherwise be paying to us to turn around to pay for our license could be used to beef up that helpline for people who are calling in and not getting a response.
Thank you.
Assemblymember Burke.
All right, there's a lot of acronyms and things, so I want to make sure I get them all right here. But I'm a little confused to the opposition. You said, I believe you said, and don't let me put words in your mouth, that you said a few minutes ago that in a decision that traditionally it is decided on the patient's behalf, usually if there is conflict, if there are two different doctors. Can you repeat that statement?
I think that was me.
Yeah.
What I was saying is, from our plan's experience, I don't have any direct knowledge of anybody else's, when one of our members ends up at an administrative law hearing.
So not till the hearing.
The hearing, but the issue was, how would an administrative law judge may be put in a position where they are being asked to make a clinical determination. Mm-hmm. And our experience has been, in those cases, the administrative law judge is very much leans towards not denying the member care, probably because of their reticence in trying to make a clinical decision. So that was my point, is that...
Then my question would be, then why does it ever get that far?
Well, you can go to administrative hearing on any number of issues,
Right.
and medical necessity would be of a clinical issue could be a very small percentage of those. So, I think the example I'm unfamiliar with the example that was given, but again, in those small amount of cases that our plan has had where a clinical determination has gone all the way to an administrative law judge, the law judge was very much predisposed to side with the member, which we do not necessarily have a problem with.
With the permission of the chair, if I could just also
Senator Monk,
comment
No, please,
on that
please,
same question.
yes.
And again, I'm the first to acknowledge the good faith of the COs in my district. They do tremendous work, as I said in my opening. But I represent the consumers, not just the plans. I represent the patients. And the example, again, of the review, and as was pointed out by the supporters, that's not the singular issue in this bill, but it's one of the important ones. When a family faces a critical decision about whether their child's going to get care, treatment, or not, and the example given of a young woman who was both suicidal and potentially homicidal, and for that to even have a hearing, they were told you won't get a hearing date. In 3 weeks, they'll give you a hearing date, which will be farther down the road still. It's absolutely inadequate. And if it's one of your constituents whose child or whose family members are ultimately at risk, to me, there's very little choice of which is the preferred system.
Thank you.
Thank you. A quick question for you, Mr. Senator. There were some comments by the opposition to the extent that COs are really strong performers and they rank high in terms of quality and consumer satisfaction. And I think there's a sort of implicit suggestion in there that additional regulation may not add a lot of value, especially when you consider the additional costs that, of course, are reimbursable, but there's a time lag for them. But during that time lag, perhaps some of the resources are directed towards regulation and oversight and away from patient care. So can you sort of take on real directly the issue of the cost benefit and the value add of your bill?
Sure, thank you. And again, our job here every day is to strike a balance. And I would say, as was pointed out in the first questioning by Assemblymember Ridley Thomas, there is a backlog for patient consumer complaints under the Department of Health Care Services Medi-Cal complaint line. We know a lot of the folks I represent are not native English speakers. They don't default to picking up a phone. What we do know, and if they get a busy signal or they get deterred or delayed, there's not necessarily follow-up. So I don't know that the data that is being collected reflects the true base of potential concerns or complaints or problems. Many of my constituents are dependent on groups like Legal Services who act as an advocate on their behalf. We do know that through the DMHC, the Managed Health Care Hotline, that was partially reorganized through legislation I carried 2 years ago, reforming the Office of Patient Advocate and creating a central referral line that's multilingual, not bilingual, multilingual, and it can use that hub to direct to Department of Insurance, Department of Healthcare Services, whoever the appropriate entity is, to resolve a complaint. And they are collecting data after their first year of that reorganization they have the complaints, where they came from, the nature of the complaint, and the time for the resolution of the complaint. I believe taxpayers deserve that type of accountability, but more importantly, patients and consumers and their families deserve that assistance and accountability. And I don't know if that fully answered your question, but I think you also raised the cost issue. Again,
I'm sure you
reimbursable fees.
Thank you, Mr. Senator. Assemblymember Thurmond.
Thank you, Mr. Chair. Senator, I'd like to ask a de novo question. Can we be done with all these letters? 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 Can we be done it's been stated that requiring, I didn't want to say codes, but we'll stick with codes, will require all kind of duplication and misuse of consumer dollars. I guess I want to ask you if you or anyone can comment on the one coast that I see that does have licensure. What is the experience? I don't know if they're in your Senate, the boundaries of your Senate district or not. Have they been wasting our taxpayer dollars, or are there other experiences that we should know about? What can we?
It's a fair question. I'm sorry, I'll defer to.
I told you I'm going to ask a new question, or at least try.
Well, we'll get a de novo answer.
Assemblymember, I don't think we can speak for the health plan of San Mateo, which is the one COES plan that voluntarily chose to license for their Medi-Cal lives. And just as the senator has stated, all of the county organized health system plans have a Department of Managed Healthcare license except for Gold Coast, so they all have some experience with DMHC. I think, Alameda Alliance in your district has both. We had, I thought, a good meeting with both departments last week where they talked about, and we've been front and center in criticizing the departments for not doing more to coordinate, and they've talked about very significant efforts over the last couple of years to make sure they do a better job of coordinating so that it's not a burden on plans. So DHCS said if the plan has sent a filing to the Department of Managed Healthcare, we don't ask the plan for it again. We just download it off their website. We go and do audits together. And so I don't want to speak for any of the plans, but we know that all of the other Medi-Cal plans, the local initiatives, the commercial plans, are doing both, and the departments are working hard to try to better coordinate their oversight.
If I could, through the chair,
Please.
I have to say that each sides have offered really compelling testimony today. This is the debate of the week for me, because what I'm quickly learning up here, it's neither in this area of government. It's neither this or it's neither that. It's a little bit of both and then some. And I think each side has presented that. I would like to ask those who are opposed to the licensure requirement to comment on the fact pattern that we heard about the young woman who was denied review, because you're right. It's compelling, costs, manage these dollars well. But to hear, what say you to circumstances of someone who is really urgently needing services, and to have an independent medical review seems compelling, and it seems compelling. The suggestion that was made that if the administrative law judge of the plan is a person doing the review, that there might be circumstances where they may not rule in favor of the participant. It does seem compelling that the independent medical review would be very important for someone in this situation, and just wanted you to have a chance to speak to that fact pattern. Sure, I'd like to. I have no direct knowledge of the example given, but just from my listening of the description of that one case, it seemed, if I recall, somebody with suicidal emergency room. Sound like if something with a lot of different needs that overlap program jurisdictions, as in department, the mental health services could be the county mental health department. The health plan would handle the Medi-Cal benefits. I can't remember, there was something autism in there. That right at the moment could be the regional centers. I mean, so you're looking at a number of different organizations charged with trying to manage this very difficult case. And it sounds like it's a very difficult case. And I think DMHC I don't think they would make it any less difficult. It sounds like it's just a difficult case of both physical and behavioral issues. Then I'm not sure if licensure would address. But I'll speak for myself, and I think I can pretty much speak for all the COES plans. We are very much in favor of our members. We have no interest in denying anybody an appropriate medical and high-quality care. That is not the issue at all. And we are fine with independent medical review. We've already offered to work to, if that is the crux of the issue, we are fine with sending it off to an independent third party. Sometimes these things are very complex, and we have no issue with it. Again, it just gets thin. That's the one thing, but you're talking about an entire layer of regulation that is also part of that, the bill that would be overlapped with that, and that's our bigger concern.
Go to a quick response here, and then Mr. Patterson.
I just wanted to respond. The issue isn't just getting medical review, it's the timeliness in which she could have it. And the Knox-Keene talks about rights of the type of urgency and how quickly something has to be resolved. And if the plan doesn't agree to resolve it and think it's an emergency, then the Department of Managed Healthcare determines it. So the issue isn't just getting access to the decision, it's in the time frame. And you just cannot access a fair hearing quickly enough for a life-threatening situation. So we had no resolution because we had no doctor even getting to the point of addressing the situation.
Did you have a response?
Yeah, actually, I can comment a little bit more because the patient in question is a plan that we represent, and I think Mr. Monning has spoke directly to our CEO about this particular case. And just to be clear that the staff from that health plan were involved in this throughout the process, and what it came down to was the family and this particular individual wanted and needed care that was not a Medi-Cal benefit, and therefore was not something that the Medi-Cal plan or the Department of Managed Healthcare could have granted on their own. And we actually, the staff, reached out and said, "Here's who you need to call. Here's the phone number." And again, this was all explained to Mr. Monning, and so I'm hearing it secondhand. But that's how it was conveyed to me, and I don't know how it was conveyed to Mr. Monning. So I just wanted to clarify that's how it was presented to us.
Thank you, Senator Monning. Would you or any of your witnesses like to add anything to this discussion?
Would you want to add to that case?
Yeah, I just want to reply that there's an disagreement about whether there's a coverage decision, and that would be the first step that the DMHC would be evaluating, or that a fair hearing process would be evaluating. Right. But a fair hearing process would take too long. The DMHC would have evaluated within 72 hours whether or not the family had a right to that coverage or not.
Yeah, and I would just underscore that as framed, it was a dispute among different potential County Behavioral Health Regional Center, the plan, but it wasn't resolved, and the ongoing lack of resolution put the patient at risk and put family members at risk. Just on this point, too, again, I'm just going to underscore this bill. The independent medical review is a critical piece of it, but it is not the only piece of it. And for the plans to say they would be more than willing to contract for independent medical review, we think it should be done in a manner that's uniform and regulated, so a patient, whatever county they might reside in, is going to be afforded the same speedy medical review. And that's where, putting under the Knox-Keene, we don't have to reinvent it. We don't have to create a patchwork of plans. We'll do it this way, we'll do it this way. We think there's a benefit to uniformity.
Assemblymember Patterson, are you okay, or would you like to make some comments?
Yeah, thank you. I think your comment just now essentially addressed what I was going to, and unfortunately, apparently you've just knocked my premise into a, because quite frankly, I think we are far apart, but so close. And it seems to me that the offer for the independent medical review and thoroughly being independent is that movement that gets us from far apart and conflicted, I think, to a place where we probably could be not on opposite sides, but unanimous on all of this. So you answered your point. You think it's got to go farther than that. I don't think so. I think we're close, and we shouldn't stay far apart. I'd like to see us close together, but if that's not where the author wishes to go, then you provide us with the role of Solomon, and we'll have to make that tough choice.
Thank you, Assemblymember. And again, as I just stated, I think the uniformity provides some benefit.
And it's less philosophical and I think practical. I don't really think one size fitting all is necessarily a excellent governing premise that ought to be defaulted to. I do think that there are certainly alternatives. I think the compelling thing here for me, and again, a conflicted set of, as Dr. Wood, has to be with how close we are, but how far apart we are, and I hope that we could get closer. But the other point is, it seems like that there is a significant and quantifiable history of really quality care here. Even you have stated how appreciative you are of it. I would just suggest we can get closer together with resolving the IMR and all shake hands and go off in unanimity. I would hope we could do that.
Thank you.
That's where I'm coming down.
Assemblymember Ridley Thomas.
Senator, having listened to this dialogue further, sounds like I could be misinterpreting what I hear people saying, that the independent review, I think you can get us on. Are you comfortable with simply focusing on that in this bill? Because the other stuff, I think you miss me on.
Yeah, well, I'm not.
Dialogue.
But again, I think you started with your question of patients, consumers not being able to get access outside of a Department of Managed Health Care hotline. That's the other benefit of this, and I don't discount that. The independent medical review captures a lot of attention because although the cases are few, fortunately, for my constituents, if it results in a suicide or a homicide of a family member or a death of a patient denied medical care, the fact that they had a hearing date 3 weeks out really doesn't make a difference to that family. But the other salient parts of this are a system that's established that every other health plan, managed care plan in the state is complying with, and it will give consumers and non-English speaking consumers access to a proven, effective hotline to both answer questions, resolve complaints, and track that data. So if it were simply the issue of the independent medical review, maybe we could. But I still feel if there's the commitment to independent medical review, why not do it under a system that already exists? And I think the benefit of the uniformity on review, a doctor will tell you not every patient should be treated with the same medicine or the same therapy. One size doesn't fit all for a patient. But with legal rights, I think we seek uniformity and predictability to protect the people that we're charged to represent.
In your mind, is there any difference in how the state should treat commercial versus COES plans? Is there any, with respect to the Medi-Cal population? So they should be the same to you?
That's right.
Okay. All right. Thank you. Senator, I don't believe I can support it today, and I'm sorry that we didn't talk earlier, but something doesn't sit right with where we are now with this bill for me.
Thank you, Mr. Senator. Thank you for the witnesses on both sides for a robust debate. Appreciate the responsiveness that you have demonstrated towards the questions asked by the members who are trying to make as informed and thoughtful a decision as they can. For me, what it comes down to is the fact that under this bill, additional and strong consumer protections will be provided to the 2.1 million Medi-Cal beneficiaries currently being served by COES in California. And I'll be supporting the bill today. Senator Monson, would you like to close?
No, I appreciate the really full and thorough dialogue. Remain committed to working with our COES groups and have appreciated the dialogue we've had moving it to this point, and would respectfully ask for your aye vote, and would just remind you we have accepted the amendments to extend the time period for plans. Thank you.
Thank you, Mr. Senator. We can entertain a motion.
Oh, I thought he moved the bill.
I'll second it. We have a motion. We have a second. The motion is due pass as amended to appropriations. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Mainshine, no. Bonilla? Burke?
Aye.
Burke, aye. Chavez? Chu? Gomez? Gonzalez? Gonzalez, aye. Hernandez? Lackey? No. Lackey, no. Nazarian? Patterson? No. Patterson, no. Ridley Thomas? Rodriguez? Santiago? Steinnorth? No. Steinnorth, no. Thurmond? Waldron? Waldron, aye. Wood? That's 4 to 4. That's 6 more.
The bill is on call and needs 6 more votes.
Thank you, Mr. Chair. Thank you, members.
Thank you, Mr. Senator. We're going to move to the consent calendar. We can entertain a motion. We have a motion and a second on the consent calendar. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Mainshine, aye. Bonilla? Bonilla, aye. Burke? Burke, aye. Chavez? Chu? Gomez? Gonzalez? Gonzalez, aye. Hernandez? Lackey? Lackey, aye. Nazarian? Patterson? Patterson, aye. Ridley Thomas? Ridley Thomas, aye. Rodriguez? Santiago? Santiago, aye. Steinnorth? Steinnorth, aye. Thurman? Waldron? Waldron, aye. Wood? Wood, aye. 12-0. Stopped.
Consent calendar passes 12-0. We have two more items. Item number 5 by Senator Allen and item number 6, SB 546 by Senator Leno. For those who are watching, staff who are watching or are here, please encourage your senator to get here as soon as possible. The first senator that gets here between Senator Allen and Senator Leno can present. Yes. We'll add on later. We're going to have Assemblymember Ridley Thomas present SB 447, item number 5 for Senator Allen.
Us West Siders stick together. Mr. Chair, members, I'm here to present SB 447 on behalf of the distinguished gentleman from, not necessary, from West Los Angeles. This revises the Medi-Cal and Family Planning Access Care and Treatment reimbursement formula for drugs and supplies dispensed by specified clinics. The Senator has expert witnesses that can testify to the merits of the bill. With your indulgence, Mr. Chair.
Thank you. Witnesses in support.
Beth Parker, Planned Parenthood affiliates of California. Our 7 California affiliates collectively handle 1.6 million patient visits a year through 115 health centers, and 95% of our patients are low income. SB 447 grew out of the experience that community clinics had the past 3 years in billing and getting reimbursed for drugs and supplies under the Family Pact and Medi-Cal programs. This bill will greatly simplify the current system to eliminate billing errors and reduce the time and resources it currently takes for us to get paid. Planned Parenthood's health centers serve as a one-stop shop. We examine the patient, handle all necessary labs, and dispense contraception and other medication to the patients. This model reduces barriers to care, increases access, and improves patient health outcomes. Yet Planned Parenthood and other community clinics have experienced enormous problems getting reimbursed for the drugs and supplies that they dispense. In the past 18 months, our health centers were not reimbursed over $40 million for drugs they had dispensed 1 to 2, in some cases 3 years earlier. We incurred all the expenses. We paid the rent, we paid our employees, we paid for the actual drugs, and all the other ancillary expenses needed to operate our centers.
We have a motion and a second. Additional witnesses in support?
Ben Avey on behalf of the California Primary Care Association in strong support. We urge your aye vote.
Kathy Mossberg, representing the California Family Health Council, in support.
Thank you. Additional witnesses in support? Seeing none. Witnesses in opposition? Seeing none. Questions or comments from members of the committee? Seeing none. Senator Allen, would you like to close?
Yes, I just want to thank my colleague Ridley Thomas. I was presenting a bill. I'm chairing a committee downstairs. I respectfully ask your aye vote. This is a very important measure to create some parity in our system.
Thank you, Senator Allen. We have a motion of due pass to appropriations and a second. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Mainshine, aye. Bonilla? Burke? Burke, aye. Chavez? Chu? Gomez? Aye. Gomez, aye. Gonzalez? Gonzalez, aye. Hernandez? Lackey? Aye. Lackey, aye. Nazarian? Patterson? Ridley Thomas.
Aye.
Ridley Thomas, aye. Rodriguez. Santiago.
Aye.
Santiago, aye. Steinnorth. Steinnorth, aye. Thurmond. Waldron. Waldron. Wood. Wood, aye. 10-0.
The bill passes 10-0.
Thank you, members. Really appreciate it. Thank you.
Thank you, Mr. Senator.